Okay, so our first speaker in the morning session on Sunday will be Kevin Sullivan of American Access Care in Atlanta, and he will share with us his attitude and strategies towards treatment.
This is a map from Zamboni of the prevalence of stenoses, and I'm going to focus my venogram talk on the jugulars and the azygos, a little bit on the ascending lumbar. I'll touch very briefly on the iliacs and renals, but mainly focus on the areas where most of the stenoses are. Clearly from the title, I'm going to talk about techniques and findings, but I'd also just like to try to demonstrate by example the range of findings, the range of abnormalities in these patients, which is quite dramatic. Access can be via either the left or right common femoral vein. There's also some discussion of using the saphenous vein, kind of an interesting idea, using under ultrasound to avoid injury to the common femoral vein. Either the left or the right can be used. The left permits evaluation for May-Thurner syndrome. Whether this really plays a role is somewhat controversial, but at least in theory, a stenosis there could impair drainage from the ascending lumbar vein. So there's some argument to go from the left over the right, although I think most people in the field debate this. I use a 9 French vascular sheath that allows me to use any size balloon that I might need during the procedure. I use the sidearm of the sheath for all of my medication and my anticoagulation. I hand an IV tubing off to the nurse so that the patient doesn't have to have an IV started. I do use conscious sedation with fentanyl and Versed. In terms of catheterization, I do, and this is mine, my formula. There are others, but this works for me. I catheterize the right and left innominative veins and the right and left jugular veins with a 5 French vertebral catheter. I start off with a stiff hydrophilic guide wire, and pretty much I can get to every patient. Almost every patient I'm successful with this. I'll show you a few cases where, a few specific instances where this doesn't work. And let me just show you some of the issues here. The problem really, in most cases, is getting through the valve. You're going the wrong way up the valve, and generally what I find very helpful is to have the patient take slow, deep breaths in and out, and that will often get the valve open and allow you to pop through. With a hydrophilic guide wire, and this is a road map here actually showing reflux up to the valve, the hydrophilic guide wire will sometimes make this a loop here or a turn. That's actually kind of useful because then you're probably at the valve, the internal jugular vein, and particularly on the left side, it can be somewhat difficult to find that. There's lots of branches here. If you recall your anatomy, both the right and left inferior thyroid veins come into the left brachiocephalic. So there are quite a few branches here, and you don't always see the valve so nicely like this. So if you see the wire make a loop like that, you're probably at the internal jugular vein. You have to pull the wire back and gently probe, and you should see the wire go straight up to the base of the skull without any deflections. I mean, occasionally you'll have stenoses or even occlusions that won't be the case, but the vast majority of cases will just pop right up very quickly and very easily. If it goes out laterally, and I'll show you the case of this later, it's probably in the external jugular vein. If it goes over towards the vertebra, you're probably in the vertebral vein. If it kind of makes a somewhat circuitous course, you're probably in some other branch, perhaps thyroid, and you need to pull out, do a venogram if you need to, or if it just makes that sort of circuitous course, you're probably not in, you probably pull out and continue to probe. So patience and persistence is often necessary to get through this valve, I guess is the message here. In terms of imaging, the most useful projections are PA and anterior shallow oblique projections. Turn the head away from the side you're imaging for 2 reasons. You want to get the jaw off the internal jugular vein, and also you want to relieve any muscular compression on the internal jugular vein with that. And I'll show you a case of that later where if the head is not turned contralateral to the imaging, you can create a stenosis. I usually perform during quiet respiration. I hand inject dilute contrast dilute about 50% so you don't obscure some of the findings. Some of these findings are difficult. They can be valves and septi, which can be difficult to see. If there's too much iodine, you may not see them. If you do hand inject, try to keep the force of injection constant pre and post angioplasty, and keep the catheter in the same position so you don't artificially create reflux or fill collaterals. This is a normal internal jugular vein, I think. It's a patient with CCSVI, but I think this is a normal vein. There's often a slight bulge where the valve is. There shouldn't be a great amount of reflux. There shouldn't be filling of collaterals. This is a classification system that's been proposed, and I'll organize part of the talk with this. Grade 1 is slowed venous outflow without reflux detected. Grade 2 is venous outflow slowed down, mild reflux, prestenotic dilatation of the vein. That's shown here. And I'll show you more examples. It's a little hard to see some of these, but just to go through the classification system. Grade 3 is outflow is slowed down with reflux into collaterals, and 4 is actually no flow down into the caudal aspect of the internal jugular vein. Skip over that. This is a grade 2. You can see a stenosis down here. This is a left internal jugular vein. And rather than seeing dilatation just where the valve is, it's kind of fusiform dilatation of the internal jugular vein. Another example, grade 2, stenosis down here, dilatation, fusiform dilatation of the vein. Sometimes that dilatation actually goes away after angioplasty. Excuse me. This is a left internal jugular vein. I've used the clavicle here as a reference, so you can see pre-angioplasty. Here's the stenosis. Pre-angioplasty, the internal jugular vein was 80% of the size of the clavicle. Post-angioplasty, you can see improved diameter, and now it's down to 66%. You don't always see that, but certainly it if you do, it helps you be confident that you've successfully treated the stenosis. Example of a grade 3, stenosis down here is a stenosis with filling of collaterals. Another example of a grade 3, just to look at some of the findings in more detail. This is a unicuspid valve. You can see here's the right side of this has a sinus, and you can see a valve leaflet. There's no leaflet over here, and this is hemodynamically significant because you see collaterals. Here's the angioplasty, and very typically in these cases, and I'll come back to this point again later, you see a stenosis. Here you see an impression on the balloon here, and and you can see it's right at the top of the clavicle here, and so it's at the very bottom of the valve. And that, in almost all of these cases, you see that's usually the tightest and the most difficult to eliminate stenosis. There's a second impression up here. Probably up in this, which is up in this area, this portion of the valve here. So, and occasionally you'll see that. You'll see multiple indentations, but the most consistent one is the one right at the very bottom of the valve. And then post-angioplasty, you can see there's improved diameter here. And frankly, on venography, I'm not totally sure whether we've somehow moved over and pushed a valve leaflet that's not moving, or we've sort of opened up this side of the valve. But in any case, there's improved flow, which is a little hard for you to appreciate because it's a static image, but there's also decreased or really no collateral filling as there was pre-angioplasty. This is a grade 3 where you see filling of collaterals. Here you see a web-like stenosis. Here's the valve, I think down here, a little bit of narrowing due to the valve, but a web-like stenosis here. And some hang-up of contrast, which you can appreciate by the contrast being much denser up above them than down below. We inflated, and again, there's a little bit of indentation here, but we've largely eliminated the web. But frankly, I think webs are hard to evaluate on venography. I think this is better, but it's a little hard to give this a percent stenosis. But the flow improved. There's less reflux than there was before. Here's an example of an internal jugular vein on the left that I was having difficult time getting into. This is an EJ. So if you see the wire bulge or kind of take a more lateral course, you're probably in the EJ, external jugular vein rather. But you can actually take advantage of this sometimes. I got into the external jugular vein, I ejected, and I thought I saw a little trickle down. Perhaps this is the IJ. I got my catheter up further, ejected some more, and indeed that was the IJ. And I used this roadmap to then get into the IJ. So you can use these collaterals sometimes to help you find a difficult to catheterize internal jugular vein. So far, I have not had to go antegrade. I've always been able to get up retrograde. But sometimes tricks like this can help you in that process. I'm showing this case just to kind of emphasize that it can be difficult to get into these IJs. Here's I'll kind of jump down to where I was at. This is the IJ here, left IJ. The vessel down here is no bigger than, there's a whole series of other veins, and the IJ is no bigger than those veins. So that, I think you can appreciate the challenge here. I think this is the valve. I'm not 100% certain, but if you see the valve, that's also a very good target. So look for that, and that will tell you where the IJ is. The right side is usually the easier of the two to catheterize. In this case, I actually had some difficulty getting into the IJ. I got into a great big, what I think is a vertebral. If you see this, I think the main point is do obliques. Make sure, know what you're in. Don't jump to the conclusion that there's an occluded IJ and try to get through this. Do some obliques. If you have any question, go back out and try some more to see if you can find the IJ. Just going to show these because they're kind of unusual. The same patients, left and right IJ is kind of an unusual presentation here. Great big collateral. We're down near the confluence with the anomina down here. Stenosis, probably some thrombus in this as well. This is a stenosis higher up, the mid internal jugular vein. I think this is real even with head turn, the contralateral direction is remains. So sometimes you do see stenoses, but most of them, the vast majority of stenoses are going to be down near the confluence with the anomina where the valve is. This is a grade 4. I kind of jump down here. You can see here's my catheter in the IJ. It's a little hard to see that. It's in the IJ, and the reason it's hard to really appreciate this is when you inject, everything goes out. You can see tremendous filling of collaterals here. So again, just demonstrating the range of abnormalities, tremendous abnormality in the venous flow pattern here. We were able to balloon this and get better flow, although still the flow is not fabulous. It's better. There's less reflux, but still not normal. Just a technical point here, most brachiocephalic veins or nominative veins are a gentle arc from the cava, prevena cava out. Sometimes you'll have a second inflection point, and that does make it more difficult, and this is something you'll see in the left sometimes. So whereas I always use the vertebral catheter to go up into the IJ, sometimes you have to try some other catheters here, like a Cobra catheter or an H1 catheter, because what tends to happen is with this configuration, the vertebral catheter will be aimed down. It's hard to turn up, and when you do turn it up, it may not engage the vein. So you may have to try some other catheters in that situation. Another example of a grade 4 where it was actually hard to opacify. This is the IJ here. You can see tremendous filling of collaterals. It's the sort of thing where you can see sometimes you have to get your anatomy book out and kind of review the collateral anatomy. I won't go through all this now for time, but it can be interesting to kind of go back and look at all this and try to figure out which veins you're looking at here. You can opacify. If you inject enough, you can opacify, but you can see what happens. It's very dense. It just sits there. But I do that mainly because you really have to see what's going on down here if you're going to treat. You need to know the vessel size and what the pathology is. But if you inject enough, eventually you can usually get this to fill. You may have to pull the catheter down. Of course, if you've had a hard time getting up there, you don't want to go too far down because you may come out, but you may have to pull it down a little bit to see this. Just a nice MR venogram of the head, just kind of reviewing anatomy here, jugular bulb, sigmoid sinus, transverse sinus, perisagittal sinus. I'm just showing this picture. This is not mine. This is a case report. I'm just showing this. This is a thrombolysis case with angioplasty. I'm just showing this to sort of reassure you that, yes, indeed, people do interventions. They put catheters and wires up there. So if you have to get up, I am starting now to go up to the jugular bulb and image routinely. But if you have to put wires up here, don't be worried about it. It's done. It can be done safely. Here's an image from my catheter with the jugular bulb injected. The head is looking straight ahead, straight forward here. And here's that lesion I described. There's a stenosis here in the jugular that's not real. It's just compression. And it can be quite convincing because you have filling of collaterals here. You turn the head to the right, and that goes away. So just important to remember that if you see a stenosis up here, make sure that you turn the head to the contralateral direction and see if it's a real stenosis or just a compression. Another finding, I'm just going to show this now. I'll talk a little bit more about this later. This is hypoplasia. And they can be even smaller than this. We have just diffuse narrowing, and these are very difficult to treat because they tend to thrombose. But I'm just going to show a picture of it now just to demonstrate it. Just going to touch a little bit on morphology of restenosis. I'm just going to show one case of this, but it's fairly consistent. What's fairly consistent is that one patient's restenose. This is December 10. This is June of 2011. They look pretty much the same. I mean, I was a little bit concerned when I was inflating big balloons, and potentially dilating areas that were normal that these patients I might initiate intimal hyperplasia. People may come back with longer segment stenoses, but so far I've not seen that. They look remarkably similar, and the results post-angioplasty are remarkably similar. Also note here again is that waist at the very bottom of the valve. Endpoints, I think I've mentioned as we go along here, you look for improvement diameter, decreased reflux. But sometimes when you're done, the flow is still slower than you'd like, and I'm not sure why that is. I've started doing ultrasound. I actually have the vascular tech in the room with me during the case. I've just started doing this, looking potentially for other things that maybe aren't fully treated. Can't really comment on that yet, but I've just started to do that, doing both grayscale and color Doppler. And just example here where we've got a pretty good result. Here's angioplasty, pre-angioplasty, post-angioplasty, kind of a nice angiographic result. Kind of confirmed in ultrasound. A lot of turbulence, reflux here. This is down where the innominate joins and the internal jugular vein comes down to the innominate. After marked reduction, much smoother flow. But we'll see where this goes. I'm not sure yet if this has a role. Okay, so what do we know about valves? I mentioned valves a bunch of times, and I've thought it might be worth just talking a little bit about valves and what we know about them. Valves, this is a autopsy, series of 100 autopsies, 87 cases had all four of those veins, both IJs and both subclavians had valves. They're occasionally absent, interestingly, the more so from the left internal jugular vein. The average distance of the valve from the innominate vein was 3 millimeters. In this autopsy series, the vast majority were bicuspid. There were a small number of unicuspid, and I showed you one of those cases. Other autopsy series, there's sometimes a small number of tricuspid valves, so there's quite a bit of variation in valve appearance. So just the presence of a unicuspid valve is not necessarily abnormal, or a tricuspid valve. The valve leaflets are usually very fine, thin structures. They're epithelial lined on both sides. Valve should keep flow going in one direction and then prevent it from coming back. And this is a sort of a two-dimensional look. 3 dimensions are kind of like a pocket, and the flow should go in one direction. When it hits the pocket, it expands and the edges coapt. These valves are pretty resilient structures. This is a series where they tried to actually make incompetent valves in sheep, and they put inferior vena cava filters into the internal jugular veins. Here it is, it's across the valve, and while the filter's in there, there's reflux. 3 weeks later, they took the filters out, and not all of them were competent, but many of them were still competent. So these are pretty resilient structures. Here's a look, kind of interestingly, I've never seen this. This is a valve with under pressure. Just looking at it angioscopically, you can see the edges nicely coapted. This is from sheep. This is a case where you can actually see the valve really well. It's a patient with CCSVI. Often you can't see the valve so well. Sometimes you do. Here's one where you could actually see the valve structure quite nicely, and you can see these are 3 per second, and pretty much this area that's this sort of a channel here that never changes, and that's the stenosis. And we dilated that, and the reason I think this is sort of instructive is that you can see the valve nicely, and if you look, I hope people can see this. I know it's kind of hard from the back down this lower row here, but the bottom of the valve is right at the top of the clavicle here, and when you inflate the balloon, that's where that tight waist is. So I think the most consistent place we have stenoses in CCSVI is the cardiac side, the side of the valve that faces the heart. And this is post-angioplasty. You can see nice opening of the lumen and markedly improved flow. Well, what do we know about valves when we dilate them elsewhere? This is a patient with dialysis patient with a graft down the forearm here. Some signs of venous stenosis. There's some other disease as well, but I saw this. Here's a valve in the subclavian, and this jet remained constant. And I think it's probably due to valves that are fixed. And I dilated this, and no waste, and take the balloon down, it looks exactly the same. That's generally been my experience when you try to dilate valves. They really don't respond well to angioplasty. But I've been looking at valves kind of carefully in some of my dialysis patients. This is a cephalic vein fistula. And I saw this and thought, gee, here's a narrowing in the vein with collaterals. And this looks an awful lot like what I just showed you in that CCSVI patient. So I kind of wondered, well, what's going on here? How is this? How does, here, now this same patient has valves here that have absolutely no narrowing, there's no obstruction, there's no limitation of flow. And one thought that occurred to me, this is pure speculation, so I'll state that as such, but maybe what we're looking at is a spectrum of valves. Maybe you have valves like this which offer no resistance. Then kind of in the middle of the spectrum you have valves like this that maybe under high flow, like a fistula, do offer some resistance. And then maybe at the other end of the spectrum, you have CCSVI. Maybe this structure here, this portion of the valve, offers resistance and obstructs flow even under normal conditions. And when you angioplasty this, here's that valve here, you get an indentation just like the CCSVI patient I showed you. You expand the balloon. Pre-angioplasty, post-angioplasty, you get improvement, decrease in collateral flow. So not unlike what I just showed you in the CCSVI patient. I don't think, there's not always, the indentation is not always just one place. It can be higher up. So I don't think this is this area down here is the whole problem. Some patients have two valves. I think maybe that sometimes is what you're seeing. There certainly are, we know there are septum. And the reason I'm spending time on this is that, maybe what we're doing, the way we're treating these need to be modified based on the pathology. I mean, if it's a circumferential narrowing, maybe balloon angioplasty is best. But if it's a septum or a valve, maybe something like a valvulotome needs to be developed for these patients. Okay, let's move on quickly to some of the other areas. I kind of focused a lot on the jugular veins. The azygous vein, I usually catheterize with an H1 catheter. And I'll kind of let me just, rather than going through all the words here, I'll just kind of show you. I usually catheterize in the AP projection, because I know where the azygous vein is. It kind of sits right where the right main stem bronchus, and at least on a chest radiograph or fluoroscopy, where the trachea and the right main stem bronchus join, and there's a shadow there. That's the azygous vein. Make sure the catheter is posterior, of course. When you inject, you'll often get just a blob of contrast, a little circular blob of contrast that will sit there. It's not extravasation. It's just contrast sitting in the azygous vein. Here it is with a subtraction mode. For the venogram, you should put the catheter in an oblique, about 45 degrees or steeper, and you may have to do a few different projections to optimally lay this out, but usually it's a steep oblique that gets the best view of that. You should be aware that there is an area just beyond the arch where you can have narrowing that's respiratory dependent, and you should have the patient take a deep breath in, and that eliminates that. The azygous can be kind of hard to image because of cardiac motion and a lot of artifact from the surrounding lung. Also be aware that in these steep obliques there's a lot of magnification, so just be aware of that when you pick your angioplasty balloon. I just want to show you that stenosis that's respiratory dependent. Here's the patient during quiet respiration. There's a stenosis here. This is my catheter, it's not a web. And there's reflux associated with this. So this looks real. I mean, it is a stenosis, but it's physiologic. When you have the patient taking a deep breath, it's largely eliminated. The reflux is gone. And also notice the whole radius of curvature changes. And this is the same. I've looked very carefully at the bone images. This is the same. The patient hasn't moved. The tube hasn't moved. It's just due to inspiration. The whole radius of curvature increases when you take in a deep breath. I'll just show you some examples of abnormalities in the azygous. Here's one in the arch associated with reflux. You can see filling of vessels. We dilated this, and here's the tip of my catheter. Actually, the tip of the catheter was up here, and my tip here is even a little bit further in, so if anything, that should sort of promote reflux, the filling of collaterals, but it's actually less. Here's one where I put my catheter in, everything went retrograde, no antegrade flow. We dilated up in the arch. This is where the stenosis was. You can see there's a little bit of a web, and these can be difficult to see or even appreciate. I mean, it's just a very subtle web there, a subtle indentation, probably a web or a valve. But then post, marked improvement. I mean, dramatic improvement. Now there's flow where there was none before. Another kind of unusual stenosis. You don't see this very often, but there's a stenosis here, I think right at the origin or the confluence between the azygous and the cava. Here's the cava here. Here's the confluence here, I think. I think this is a jet. This is artifact. We dilate it up. Again, nice improvement in diameter. Less reflux post-angioplasty. Another example, just beyond the arch, kind of a regular narrowed arch here. Very, very marked filling of collateral branches out to the point where we're almost getting tissue blushes. Post-angioplasty, better, still somewhat irregular, somewhat narrowed, but marked decrease in reflux, but again, not a perfect outcome. A stenosis down a little bit further in the azygous. It's a little hard to understand what was going on. For me it was, and I think it is even, in retrospect, it's a little confusing here. You see sort of a small arch, azygous arch here, a great big, somewhat dilated, Azygos more peripherally. I put my catheter down, and it's very dramatic. The flow is all retrograde through a big collateral, probably going up into the superior intercostal vein, into the left brachiocephalic, and we dilated this as well. Move on a little bit here. We're running out of time. This is left iliac venography can be performed via the sheath. I don't have a lot to show you on that. I've not really done much with that. The ascending lumbar veins, I'll show you some examples of that. This is something you can get into with a vertebral catheter. Hand injection, you should see these nice structures here, these nice octagonal structures. What they're coming from is when you inject, when you look at the ascending lumbar, there's suprapeducular veins, infrapeducular veins, there's anterior vertebral veins, and you see them here on this cross section. They're anterior because they run the anterior of the spinal canal. Here again, a very nicely demonstrated venogram. But in these CCSVI patients, often you won't see that. You'll see, here's an example where you see stenosis of the lumbar veins. There's no filling above this, probably stenoses or occlusions. You don't see those nice structures that I showed you on the others filling. And here's another example where maybe a little bit of narrowing of the ascending lumbar, but none of those branches are seen. One level, you see some branches. There's not much. I haven't done anything. I don't know if anybody has tried to do anything with these. I suspect if you try to go out into these and recanalize them, they'd probably just thrombose. So I've not done anything with these, but it does, at least if you have a patient that you treat and doesn't get better, you at least have some idea why they have not. Left renal vein can be catheterized with a 5 French H1 or a Simmons catheter. Again, I have not done much with this. Some of the other people on some of the speakers have and might want to address this. And I just want to show one more case here. I think just to demonstrate that these patients can have some pretty widespread abnormalities to the venous system. I mean, this is a patient where I put a catheter from the groin. My wire kept, I thought I was in the superior vena cava, and my guide wire kept going in this direction. Injected contrast, and I was in the azygos vein. This is the azygos arch. Great big high flow azygos arch going into the cava. Pull my catheter back. And this is the inferior vena cava, and here's the inferior vena cava. It's a little thread. Great big collateral into the azygos. I sort of thought a bit about what to do with this and decided, well, probably it isn't good for the drainage of the azygos vein to have all of this flow, maybe increasing pressure. So I decided to open this up. I got a balloon up in here, dilated. Now most of the flow from the cava is going the direction it should go. I think this is the renal vein here, and I think this is just a big collateral. But again, just to emphasize that these patients, I think these patients can have venous anomalies beyond those that we routinely look at. So in conclusion, the techniques that you need for this procedure are well established. If you're doing percutaneous interventions, you probably are familiar with them. In terms of the findings, the etiologies are different, and the stenosis can appear quite different than other things you may have seen, like patients with dialysis, grafts and fistulas, May-Thurner's FVC syndrome. These are largely due to valves and septums and webs, and can be somewhat difficult to see. And hopefully I've demonstrated the range of abnormalities, and they can go from rather subtle, I think some of the stenoses in the azygos arch are frankly quite difficult to see, to some very dramatic, those grade 4s where most of the flow is retrograde into collaterals. Thanks.